So now we can start the treatment of the soft tissue dehiscence around the implant. It's something that I started more than 10 years ago, and for many years I did not publish and I did not show these clinical cases because it seems impossible to treat some like this exposure of the implant surface, of this alignment of the soft tissue margin at the level of the implant supported crown with the soft tissue only, without speaking about bone or substitute of bone. Now the things are completely changed, and I think that all the scientific literature and all the scientific world believe that the only way to treat this defect, which belongs to the buccal aspect of the implant, and which means that the implants is perfectly osteointegrated, so there is no problem of infection in terms of infection of the implant surface with loss of bone. It's only with the soft tissue and not with the bone or bone substitute. Obviously, the reason for this is quite clear. We said that the main etiological factors, or the main factor associated with the development of this soft tissue dehiscence, is too much buccal displacement of the implant, or too much buccal angulation or emergency of the implant shoulder. So if the implant is placed too much buccally, it's not by adding the bone filler material that you can create much more buccal bone, because this is completely not possible to be obtained from a biological point of view. So the only way in order to mask this anesthetic aspect is by increasing the soft tissue thickness so much in order to replace such a thick transmucosal soft tissue that can mask the disalignment or the metallic exposure of the implant surface. So for sure, the only treatment that can be considered in these clinical cases of well osteointegrated implant with aesthetic defects, which are limited at the buccal aspect, is the soft tissue augmentation procedure. Let's say that the first attempt or the first publication in these fields is not so old. As you can see, it was in 2008, in which an attempt or a study was made to cover this soft tissue dehiscence with a surgical technique, bilaminar technique, so a connective tissue graft plus a corneally advanced flap. No mention, no way, no prosthetic treatment was done in this article, but the objective was to try to treat this dehiscence in the same way as the recession are treated around teeth, leaving the implant-supported crown in position, because this would be ideal for the patient, and also from economic point of view, that you don't have to make a new crown. But from the result of this study, we can say that the coverage, and in particular the complete coverage, which means the capability to reposition the soft tissue margin at the same level of the homologous contralateral tooth, is really unpredictable. So the result of the study, which is a quite short-term study, demonstrate that also the short-term outcomes are not satisfactory, and as much as the time passes from 3 months to 6 months, there is a worsening in the coverage, namely some further recurrence in the original recession that was present. So from this data, we can consider that to treat implants by leaving the implant-supported crown and to use the traditional bilaminar technique to cover this dehiscence, it's something that does not work. So what we did many years, not many, but 4 to 5 years later, even if, as I told you, it's something that I was doing from many, many years before, I will show you cases of 10 years follow-up. it is a completely different story. It's a combined prosthetic, surgical, prosthetic treatment, which is much more complex, which means that a lot of treatment must be made also by your restorative dentist in order to succeed. I'm speaking about succeed because the outcome of this study were really very, very positive. And the first positive outcome of this study that I can share with you is the 1-year soft tissue thickness. So after the therapy, we started with a mean thickness of 0.9, which obviously was not enough, and we end with a medium mean value in soft tissue thickness of 2.5. This 2.5 is a value that is very, very safe in terms of risk for gingival recession recurrence, because we really have such an increase in the thickness that the risk for gingival recession is very, very low. While the second outcome, that is the first outcome for the patient, how much of the exposed implant surface was covered with this combined surgical and prosthetic procedure, was 96 of the previously exposed surface, which is very nice data. It's incredible positive in terms of percentage, but it's also very, very great, the outcome we were able to achieve in terms of complete coverage. And I want to remind you that complete coverage means that you are able to replace the soft tissue margin at the implant-supported crown exactly at the same level of the soft tissue margin of the adjacent natural tooth or homologous natural tooth. This is exactly what the patient would like to see, so to have the natural tooth and the adjacent implant crown exactly at the same level. And these values, 75% in complete coverage and 96% in mean root coverage, are very, very close to the outcome we can achieve in the treatment of gingival recession around teeth. I'm speaking about those situations in which the bone is intact, while you know that this is not exactly the same what we can achieve when we speak about implants in which the bone obviously is not as intact as in the situation of gingival recession in the first and second Miller class, where the interdental bone is absolutely perfect. But as I'm going to share with you, this is not only a simple surgical procedure that can be made, but a much more complex treatment. So we can start with one of these clinical cases. In the picture on your, which is this, left, you can see the situation I've never seen that the dentist sent to me before. This was before his treatment, because this was the situation of the implant-supported crown 2.5 years after implant installation, in which the patient was absolutely not happy because of the color also of the crown, the color of the soft tissue, and also because of the general bad aesthetic outcome of the surgical procedure. The dentist who sent me the patient also tried to do something, as you can see during this time. It was a free gingival graft that was applied at the buccal aspect of this implant-supported crown in the attempt to mask the transparency, the color, but also to improve the coverage. And you see that some nude keratinized, but even a lot of scarce tissue was formed due to this procedure, but completely not covered was achieved. And if I can tell you, maybe the length of the implant-supported crown is even longer with respect to what it was about 1 year before the treatment with the free gingival graft. So this just to tell you that free gingival graft cannot be ever the right treatment to cover the soft tissue dehiscence around the implant, because there is no blood supply when you apply this graft on the crown and on the implant surface or abutment surface or whatever it is. This is only way by grafting if you want to increase the keratinized tissue. And since this is something that can be applied in the posterior area where aesthetic is not critical, when the position of the soft tissue margin is not critical for the patient, in which you just want to increase the capability of the patient to clean by improving the amount of keratinized tissue, but not for sure in the aesthetic areas. When I saw the patient, there was a disalignment of the soft tissue margin and a lot of scar tissue coming in part from the previous surgical procedure that was done in order to increase the keratinized tissue by grafting. The level of the bone was not bad. The implant was placed really not so well. You will see too much buccally inclination with the too much buccal emergency of the implant shoulder. And this was the consequence of the immediate post-extraction implant that was adopted by the previous dentist, who made also some bone augmentation procedure at the buccal aspect together with the immediate post-extraction implant. The level of the bone, obviously there is some bone loss, which is due to the bad implant installation, but not for sure to perimplantitis. The whole implant surface is completely surrounded by bone. There is some obliquity of the bone crest, which is due to the implant installation, but not to perimplantitis at all. Obviously, the area here, you can see black, mesial and distal, which correspond to the area of the papilla, is not supported by bone as it is in the presence of the natural dentition, whence the bone is intact. And this is very important because now we are going to speak about papilla area. And when we speak about the papilla area around this crown, we have to consider that the bone underneath is not completely intact. So, which is the key factors for covering these soft tissue dehiscence around single implants, with the objective, obviously, to give the patient a crown, implant-supported crown, that is exactly like the adjacent natural tooth. The most important aspect is if soft tissue augmentation must be made, and if this soft tissue augmentation must be made by using a connective tissue graft, where it's the ideal position of this connective tissue graft. And I think that you agree with me that the connective tissue graft, which means the way we use to increase the soft tissue thickness, so to reach a soft tissue thickness that is at least 2 millimeters at the same level of the soft tissue margin of the homologous tooth, is a bit more corner with respect to the soft tissue margin of the adjacent tooth. So we straight ideal line with respect to the soft tissue margin of the adjacent tooth, and we would like to place our connective tissue graft a bit more corner. Why a bit more corner? At least for 2 reasons. The first one is that we know that there is some risk of shrinkage. Every single time we speak about soft tissue, we cannot think that where we place the soft tissue, it stays there. There is risk of shrink. And so if we place this a bit more corner, we know that in the case of shrinkage, we have the right thickness at the same level of the soft tissue margin of the adjacent tooth. The second aspect why I'd like to place this graft more corneal with respect to the soft tissue margin of the adjacent tooth, it is because if everything goes well, and so I don't lose any height, so if there is no shrinkage at the end, I can give my restorative dentist some tissue in excess that can be conditioned by my restorative dentist and give the right thickness at the same level of the soft tissue margin of the adjacent tooth with the restorative phase that can be used not only to condition the soft tissue apical, but also to condition the soft tissue lateral, so the situation of the papilla. When you work as a restorative dentist, you would like always to have tissue to push apical and reach the same level of the homologous tooth, because this is the best way to achieve a good aesthetic outcome. And this is why I would like to place my graft more corneal than the soft tissue margin of the adjacent tooth in order to increase the thickness and the height in excess and make my restorative work much more aesthetic. The problem is, can a graft survive in this position if I keep the crown of the implant supported tooth, of the implant? Obviously, there is no blood supply at all for that portion of the graft that is placed above the crown. And also, the possibility of this graft that is placed above the crown to survive depends if it is covered or not by a blood supply. If I tunnelize, it means that only that portion of the graft that you can see mesial, distal, and apical with respect to the graft can be tunnelized and so can receive blood supply thanks to the presence of some tissue covering it. The question is this area of the connective tissue that is left exposed can it survive above the crown if the whole other portion, even larger maybe, is placed above the soft tissue? We don't know. Maybe yes, as much as the connective tissue is receiving blood supply from the adjacent soft tissue, the greater is the possibility that a smaller area of the connective tissue that is left exposed can survive. My question is, this portion that is left exposed, or partially exposed if you want, can it survive with the right thickness that I need? I need this portion of the graft survive with a thickness that must be greater than 2 millimeters, we said, because this is what I want at the level of the soft tissue margin of the implant-supported crown to prevent gingival recession to form. So the question is, if I want to have some graft which is left partially exposed that survive with a thickness that is equal than 2 millimeters, the question is, how much thick should this graft be? If left exposed, and if it left exposed, I know that some of this tissue is lost with the right thickness of 2 or more. So I would need, I don't know, a thickness of the graft that is more than 3, maybe 4, I don't know. And so the only area in which I could think that this graft can be taken with the right thickness to survive with this very, very critical thickness is only the area of the tuberosity, because there is no way to have such a thick graft in any other areas of the palate. Because if you go deeper in the palate, you can take more submucosal tissue, which means fatty and glandular tissue, but not dense, rich, collagen-rich connective tissue. So as much as this connective tissue graft is made of fatty and glandular tissue, there's much more this lose thickness with time. And so we need a very dense. But leave the connective tissue of the tuberosity also comports some risk of necrosis because it's less vascularized. And so I think that from a biological point of view, and also from an aesthetic point of view, because let's say that this survives, but what is the color? What is the texture and the surface characteristics of that portion of the graft that is left exposed? Is exactly the same of the adjacent teeth. It's very rare, and you cannot rely on this when you speak about aesthetics. You are treating a patient for aesthetic reasons, because the patient does not have any problem for chewing. The implant is perfectly osseointegrated and perfectly stable. The problem is aesthetic, and so you have to give an aesthetic outcome to our patient. So I really think that the tuberosity is not the solution. Increasing the thickness of the graft is not the solution. I think that the solution is to cover the graft completely. Because if you believe that the whole graft is completely covered by a flap, you have two great advantages. First of all, you can join the two thickness, that one of the graft and that one of the flap, to reach the famous 2 or more thickness at the level of the soft tissue margin. So I can measure the thickness of my flap, which is also 1 millimeter by itself. And so to reach 2.5, which is even too much in truth, you only need 1.5 millimeters of graft, because this graft, since it remains covered, it does not resorb and lose thickness as the uncovered graft. So I'm not speaking about a tissue that should be 3 or 4, but I'm speaking about a graft that can be 1.2, 1.5 maximum. Do you understand? By using also the double layer. Double layer means flap plus graft. And this is an incredible advantage also for the patient and also for you, that while tuberosity, it's something that is not so frequently to be available with the right dimension, mesial distal. This mesial distal dimension is more than 10 millimeters. And how many patients have a tuberosity whose mesial distal dimension is 10 millimeters? Almost none. It's very rare. Tuberosity is 6, 7, 8, but 10 or 11, it's very, very rare. But it's very critical for you that you can take 1.2, 1.5 millimeters of connective tissue only. You can take whatever you want. There is always some area in the patient palate that can give you a graft of about 1.2, 1.5 millimeters. So no problem to find it, and even less problem for the patient, because even if it does not have the tuberosity, you don't have to go so deep to take some tissue that is not predictable to be remain, because it's made prevalently of submucosal palate. So the second great advantage, obviously, is that if you cover the graft, it is the connective tissue of the flap that gives the quality of the keratinization, and so the color, texture, and surface characteristics is not more influenced by the connective tissue taken from the palate, but it's influenced by the covering flap, and so from an aesthetic point of view, this will match better with respect to the exposed portion of the graft. So I think that you must agree with me that the better solution would be to cover this graft so you can reduce the thickness of the graft. It's better for the patient, it's better for the aesthetic, but also it's better for the graft. Because if it's completely covered, the possibility for this graft to survive even above an avascular surface is increased by the fact that it's completely receiving blood supply also from your covering flap. The problem is that this flap must receive blood supply in a more coronal position with respect to the position of the connective tissue graft in order to survive above this graft. The only area which can be vascularized, so blood supply, in a more coronal position with respect to the position of the graft, obviously, is the area of the papilla. I don't see any other areas more coronal with respect to this graft And this area of the papilla are so critical in order to maintain the covering flap in a more coronal position with respect to the connective tissue graft and continue to cover the graft not only during the healing, but during the whole patient life. And what is this papilla area? I have to consider that this papilla is the blood supply for the flap. And so if I want blood supply coming from the papilla, I have to remove the epithelium from the papilla. So I have to consider this papilla once they are desepithelialized. And so now you have to think about this papilla with a triangular shape, very, very acute tip. Once they have been desepithelialized, how much connective tissue bed do you leave there? Remember that this papilla does not have bone intact below because it's implants, it's not teeth. This papilla comes mostly thanks to the conditioning effect of the crown, so they have been squeezed by the temporary and by the definitive crown of the previous dentist so that they can achieve a triangular shape, feel the interdental contact, but they are most considered false papilla in terms of blood supply because they are triangular, mainly made of epithelium with a very, very poor core of connective tissue. So if I desepithelize this papilla, I have no blood supply. And this is something that also the study of 2008 tells you that most of the time, maybe, we don't know, but the reason for the incomplete success of the treatment of recession around the implant-supported crown, keeping the crown in position, is because you don't have enough papilla, enough blood supply for the covering flap to remain covering the graft. So this papilla is not enough. It's not enough because it's of the wrong shape, and it's really too thin, too poor of connective tissue once they have been desepithelialized to provide blood supply to the covering flap. And how can you increase the area of blood supply at the level of the papilla? Obviously, if you remove the crown and if you change the abutment so that the old abutment is substituted by a surgical abutment that is so thin, so narrow, that a much more space can be left from the two adjacent teeth and such a very, very thin abutment, you can leave the soft tissue that was squeezed by the crown to fill back this space that is now left available for the soft tissue. And with time, you will see that the whole area, which was previously occupied by the crown and by the old abutment, is now filled by a very dense, collagen-rich, mature connective tissue, which allows me to make the surgical procedure with trapezoidal surgical papilla and no more with triangular. What does it mean, trapezoidal? It means that instead of having only a triangular tip that once it has been desepithelialized, nothing remains, you have soft tissue isthmus. That means that this area not only leave some connective tissue once you remove the epithelium, but you can use this wider area and extend the desepithelialization towards the palatal aspect because of the dimension and the distance between the abutment and two adjacent teeth, and extend the vascular area towards the occlusal and towards the palatal aspect of this papilla, which is not more a papilla, but it's a supracrestal soft tissue. So it is exactly the same topic that we covered when we spoke about periodontal regeneration procedure It's a completely different story when you can manage with the soft tissue of a papilla shape, triangular, with only epithelium, with respect to a trapezoidal shape in which you have a soft tissue isthmus that can be used clinically to extend your desepithelialization towards the palatal aspect. And how long does it take for the soft tissue to fill this space? It takes time. And it takes time during which there should be no temporary crown interfering, so occupying the area that should be filled with the soft tissue. So the patient must accept to wear during this period of time, that is never less than 2 months, sometimes 3 months, depends on the quality of the connective tissue, depends on the patient, depends on many, many things that maybe we don't know. How long does it take for the soft tissue to fill the space? But what I can tell you, that it never happened in my clinical case, that this does not occur. I remember the patient from Turin that it took about 6 months. But if I show you the picture of this patient, when I started, there was no papilla at all. 6 months after, there was papilla that was almost intact. So you have to wait, and the patient must not be in a hurry. And the patient is in a hurry because she's wearing a temporary crown that is short with some metallic exposure of the abutment, and so she's not happy. But you know, this is critical for the success of the surgical procedure, because if you make the surgery with triangular type of papilla, you are going to fail. So in no less than 2 months' time, this area is now completely filled with connective tissue that can be desepithelialized in the vertical, in the horizontal plane towards the palatal aspect, and give blood supply. To what? To the surgical papilla of the coronally advanced flap. And obviously, in order to make as much as connective tissue surface in contact in the interproximal area, you have to prepare in your flap, that will be coronally advanced for sure, surgical papilla, which is always also trapezoidal. Exactly in the same way we know we treat single type gingival recession, we make large trapezoidal type of surgical papilla so they can join, in this case, with trapezoidal anatomical papilla, desepithelialized, and so to give such a wide connective tissue contact, surgical above anatomic papilla in the interproximal area. That is the key factor for the success of the covering of the implant and abutment surface. So full coverage of this connective tissue is critical for the success. In order to have full coverage, you have to give the greater blood supply to the papilla, mesial and distal, to the abutment, to the flap that will be coronally advanced and will be used to achieve complete coverage of the connective tissue graft. As you can see from this picture, if you may, or if you try to make the same surgical procedure by leaving the implant-supported crown in position, you see that more than 80% of the vascular bed you may have used surgically by working on the abutment, reduced abutment, no crown, is occupied by the crown, which is completely avascular, and this tells you why it's so risk to fail if you try to make the same surgical procedure, namely connective tissue graft plus coronally advanced flap by leaving the implant-supported crown in position. So now we can see the step-by-step procedure of this clinical case. And I want to share with you the picture only 7 days after removal of the crown and change of the abutment. In these seven days before the patient gets to us, the crown was removed, the old abutment was removed, and an impression of the platform of the head of the implant was given to the technicians to prepare the narrowest and the smallest, the thinner abutment as possible. When I speak about narrow, I mean that we have to use an abutment that is no more than the screw that connect the abutment to the implant. When I speak about thin, I mean that this abutment should be made of a tissue, of material that can be really thin with no risk of fracture, so that an increased space can be maintained from the abutment and two adjacent teeth. Because my first request to the technicians is always to give me a zirconium abutment. Why? Because it's white. And even if you have to leave it exposed, during this time it takes for the soft tissue to fill the space, the patient is much more happy because she shows something that is white and not gray, not metallic. But most of the time, especially once the implant is very buccally displaced, the technicians tell you that if you want an abutment in zirconium, he has to leave much more zirconium, much more thickness of material, not to prevent risk of fracture during the healing, because this abutment must last for about 6 months before being changed. And 6 months, if the zirconium is too thin, you have risk of fracture. So sometimes you cannot work with zirconium abutment, and I tell you that most of the time, as much as the implant is placed worse, the greater is the possibility that you only have metallic abutment, so that you can keep the thinner as possible the metallic with respect to the screw, and the narrow as possible this abutment with respect to the head of the implant. But in only 1 week time, you can see that there is already a great change. The first change you have to notice is the keratinized tissue apical to the abutment. Since there is no interference of the temporary crown that is left short, there is the tendency of the soft tissue to creep, which means to cornerly cover part of this abutment. Why? Because it's a very smooth, clean surface that is favorable for the growth of the soft tissue above it. And you can see that in only 1 week time, that this alignment with respect to the soft tissue margin of the previous crown and the level of the soft tissue margin of the adjacent tooth is almost completely resolved. And this is very critical, because if you improve the quality of the tissue here, if I improve the thickness of the soft tissue here, I can also reduce the thickness of the graft, but I also can improve the stability of my flap once it will be coronally advanced, and so it will remain stable because it has good thickness of keratinized tissue to start with. So even if the patient asks us, can you please give me a temporary crown that masks this metallic exposure? You have to say, unfortunately, I cannot. You have to leave this crown, temporary crown, always short with respect to the soft tissue that is filling the interdental space, and also with respect to the keratinized tissue that is growing coronal. Otherwise, you will not see an improvement, because it's the temporary crown that will be an obstacle to the soft tissue increase. So there is no other way. If there is a patient, I can tell you, if there is a patient that really don't want to accept this, the only way is to place an abutment and to mask this abutment underneath a Maryland solution that is done only for aesthetic reason, but this is something I don't like, because if there is a Maryland above the abutment, the capability to the patient to keep, to clean, but also to brush in the correct way in order to improve the soft tissue is much less, or let's say very, very much less. So what you have to make your patient understand that in order to succeed, there is this phase that has to be done because it's more than critical for the success than the surgical procedure. You see that in 2 weeks' time, the keratinized tissue has improved. The level of the soft tissue margin is exactly the same. 2 millimeters of coverage we achieved in 15 days by removing the crown and changing the abutment. And also, the interdental soft tissue is changing completely its shape from a triangular to a more trapezoidal shape because it's filling this area. But don't believe that 2 weeks is enough, even if you see some improvement. It means that this area must be used as anatomic papilla to be desepithelialized intrasurgically. So it must be connective tissue that is as much as dense, as mature as possible. So you don't have to make anything before at least 2 months has passed from the time where you remove the crown, change the abutment, and put the new surgical abutment with the very, very short implant-supported temporary crown. 2 months later, it's a completely different story. It's so incredible what the soft tissue can do by themselves if the patient is able to clean very, very well. Soft toothbrush, chlorhexidine once a day in order to improve the plaque control in this area. And you have to see this patient every single month to remove the temporary crown, to perfectly clean the abutment, and also to check that there is no contact between the temporary crown and the soft tissue, because if there is a contact, you have to reduce your temporary crown even more, leaving even more space for the soft tissue to fill this area. And until you don't see that this connective tissue is so completely attached, not attached in terms, obviously, of attachment, but very, very tight against your very, very narrow abutment, you don't have to schedule your surgical procedure. Because as much as you gain in terms of quality, the more predictable is the success of your surgical procedure. At a certain point, you cannot pretend any more improvement because the abutment becomes, as much as you go corner, so much buccally displaced due to the bad implant positioning that the soft tissue cannot grow above something that is exactly on the opposite direction with respect to the ideal direction for the creeping. And so at a certain time, when you see that the connective tissue is very dense, is very mature, and there is no change between the previous control you have done 15 or 1 month before, everything is remained almost the same from a clinical point of view, this is the time to schedule your surgical procedure. And your surgical procedure should be scheduled in order to achieve now the increase in the buccal lingual dimension, more than increase in the apical corner, because most of this increase was already reached by the keratinized tissue by itself. But now you have to think that your soft tissue margin, which is even more corner than the soft tissue margin of the ancient tooth, must be placed more corner. Why? Because the connective tissue graft must be placed more corner than the soft tissue margin of the ancient tooth, and your flap should be placed even more corner to protect and to cover for the rest of the patient life your connective tissue. So the amount of corneal advancement is reduced, but you must not think this is enough. Otherwise, you will experience graft exposure, and if you have experienced graft exposure, you will not finalize with the right soft tissue thickness at the level of the soft tissue margin of your implant-supported crown. And so if you look what happens in 2-3 months' time, it's almost incredible. So the whole recession was almost completely solved by the soft tissue itself. The improvement of the quality of the keratinized tissue and the thickness of this keratinized tissue is clinically evident, so you can use thinner graft and use good amount of keratinized tissue to stabilize your flap. And what is really incredible, and how this soft tissue has the capability to really fill the space that was previously occupied by the implant-supported crown. So now, instead of working with a triangular, narrow tip, epithelialized papilla, you have to work with very, very wide supracrestal soft tissue that can be used at the time of the surgery as trapezoidal anatomic papilla to be desepithelialized in occlusal and palatal direction.